Ready? Guys, I'm sorry for the late start. We're trying to make sure that everybody is accommodated and the live stream is operating, so if you'll just give us a few moments, because there are many people that are tuning in from their home. So we're just waiting on to make sure the technology is ready, and we'll start the meeting. All right, I think we're ready. I'd like to welcome everybody to the Insurance Committee meeting tonight. We are going to start this one a little differently than we do most committee meetings. I think it's more important tonight than ever to pray, and I've asked President Bamberg to pray us in, and so we can start this meeting, and then we'll lay some ground rules. So, President Bamberg.
Let's pray. Dear Heavenly Father, Lord, we just want to lift up the people that came to the meeting tonight, Lord, that you just deliver them home safely tonight, Lord, with your protection. Lord, we want to pray for this board as we make the decisions that affect our retirees and our employees, Lord, on a daily basis, Lord. So just be with us as we, on our conversations tonight, and let our conversations please you. In your precious name I pray. Amen.
Amen. Please join me in the pledge.
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation,
Good evening, everybody. We're going to start with a few ground rules just so everybody understands the process. I understand that we have overflow in every room. It is not our doing. We are limited to 50 people per room by the mandate set by the governor. So we are adhering to that. I understand there's also paper that's run out in the lobby for questions. I just want to start by assuring everybody, if you want to speak, you are going to have the opportunity to speak. We are going to hear from experts this evening that are going to be able to address options that we're looking at, address concerns, answer questions for everybody, and we're going to try and take it one step at a time. All that I ask is that we keep everything civil and everybody will have the opportunity to get their questions answered. As far as discussion, if you have a public topic that you would like to discuss, talk about, there will be a 3-minute time limit that we will keep from the stage, and we will raise our hand when we approach that 3-minute time limit so you don't feel as though you're cut off sharply and can finish a thought. So we're going to start this evening. Agenda item number 1, discussion action, possible changes to insurance benefits, presented by Michael Guyton of CHR Partnerships, Jason Allman of the Allman Group, and CFO Nisha Bamberg. So we're going to start with Mr. Guyton on Medicare Advantage. Mr. Guyton, you have the mic.
Y'all have the presentation you can put up on the screen. Do you have the presentation you can?
Yeah. Stewart.
Where'd he go?
Where'd Stewart? Okay, Stewart's checking on the broadband. He's coming. Make sure everybody that is at home has a chance to watch too. There we go.
Okay. So I'm going to start off with these are just, we're going over the benefits of your current plan today as it is and the 2 plans that the school board is entertaining. You can see on the far left there where it says Blue Cross Blue Shield Group Care Copay PPO. That is your current plan, okay? Out to the right, you've got Blue Cross Blue Shield Medicare Advantage and United Healthcare Medicare Advantage, okay? I'm just going to go down line by line, and we're going to go through these benefits. So currently today, your calendar year deductible is $0. You can go across the page, and you can see that's 0 for Blue Cross and also 0 for United Healthcare, okay? Out-of-pocket maximum, that includes your deductible. With currently, it's $4,000, $1,000 for Blue Cross, and $1,000 for United Healthcare. Lifetime max is the same on all 3 plans. It's unlimited. Your office visit copays to go see a primary care or a specialist is 0 all the way across. Same thing with your x-rays that are included with your office visit. It's 0. You're not exposed to anything. Hospital inpatient. Again, 0s all the way across the page. And I know this is getting redundant, but outpatient services, your MRIs, CAT scans, surgery facilities, mental health issues, substance abuse, those are all 0s, and you can just go across the page. Other services, your emergency room services. Currently, you have a $0 copay under the current plan. If you go to an emergency room, under Blue Cross, it would be $50, and United Healthcare, it would be 0. Urgent care is, again, 0 across the page. Your current plan, if you need a wig because of cancer or something else like medical and necessary, you can get 1 wig under your current plan, and Blue Cross will pay up to 80% of that. You'll be responsible for 20%, which will go towards your max out-of-pocket of $4,000. Blue Cross, there's no, you don't have a benefit with the wig. There's no wig allowance. You have a $300 wig allowance with United Healthcare. Private duty nursing, currently, if that is not covered by Medicare, Blue Cross would pick it up, so that would be subject to your deductible. If you have to have a nurse come and stay in your home and help treat you, that would be subject to your deductible and 20% coinsurance. Under Blue Cross, there's not a benefit for that because it's not covered by Medicare. United Healthcare would give you a $10,000 allowance, okay? That's the medical coverage, the highlights basically of the medical coverage. I'm going to go over the prescriptions below. Prescriptions, currently you have a $10 copay for Tier 1, Tier 2 is 30, Tier 3 is 70, when Tier 4 is 10% with a maximum of $100. With Blue Cross, it's the same thing. The 5th tier is an additional, and I brought John Whittemore with Blue Cross here. He's the expert that actually works for Blue Cross down in Baton Rouge and is over all of these plans. And that last plan is just a 5th tier for your specialty drugs. United Healthcare, same copays as you have today, 10, 30, 70 with the 10% on the specialty tier with the $100 maximum. Your current mail order is 3 times, okay? Under Blue Cross, that would be the same, so you could still get your mail order prescriptions for 3 copays. Under United Healthcare, it would be 2 copays. Your maximum out-of-pocket today, so right now, and going back up on that page, right now, you have a $4,000 maximum out-of-pocket, okay? That includes your office visit copays, which you don't have any, but I'm used to speaking to commercial groups. That includes anything that basically you come out of your pocket in network. So whether you pay a copay for your prescription drugs, which most of that will go towards, if you have to pay something for private duty nursing, everything else in your plan is pretty much 100%, okay? So those prescription copays are going to go towards your max out-of-pocket of $4,000. Under Blue Cross, those prescription copays would be limited to $2,500. Okay, same thing with United Healthcare. So it's a little bit less. You have no prescription deductible on any of the plans, and then you're out of network. Again, it's the same thing across the page. And their out-of-pocket maximum is still the same out of network. But on both Advantage plans, the benefit pays the same benefit in or out of network. So you're not exposed to anything. The only thing you're going to really collect towards your out-of-pocket maximum, the majority of stuff is going to go towards, it would be your prescription drugs. Under Blue Cross, you do have that $50 copay for emergency room, but if you were admitted to the hospital, that would be waived. So that would go back to 0. Are there any questions on these plans? Is this now when y'all are opening it up for questions, Adam, or?
No, I think what we're going to do, since the gentleman from Blue Cross is here,
Yeah,
if he'd like to make a statement or talk about these benefits, or, I know you're here from the company, so we'll give you an opportunity to speak on the Medicare Advantage product offered from Blue Cross.
Sure, thank you. Here to answer any questions you really have, but I also want to make sure there's a clear understanding of the difference between a Medicare Advantage EGWP, an individual Medicare Advantage plan. I know there's been talk about the standalone RX EGWP, and there's a lot of confusion about the different plans. So I want to make sure we get that addressed and answer what questions y'all may have. So I don't know if you want to go through that format of a Q&A, or do you want me just to kind of give a high level the differentials?
Excuse me. We have a whole lot of Q and A, so
Correct, so I don't know how you want me to tee
I'd
it
like
up.
you to go through it first to explain some of the high-level stuff, some of the,
Sure.
the frequently asked questions,
Yep.
that type of thing, please.
All right, so the best way to start out is in 1997, the Budget Reconciliation Act back in the day created a situation where the government brought in private insurers to partner with CMS, Centers for Medicare, to instill innovation and partnerships with delivering Part A and Part B Medicare to seniors. You fast forward to 2003 with the Medicare Modernization Act that brought us Part D, which you're discussing, but it also created EGWP. And the reason those are put in place is Congress put these programs out there for organizations like yours to help take care of the seniors that have been promised benefits. Because at the end of the day, you make promises to take care of the children who you're focused on educating, but also how do you fulfill the promises of these seniors and these obligations we've been taking on. So when Congress passed the Medicare Modernization Act, they put out the retiree drug subsidy, which you all have taken advantage of. But they also created EGWP, which is employer group waiver plans. So waiver in employer group waiver plans gives insurance companies that partner with CMS, the Centers for Medicare and Medicaid, the opportunity to structure group benefit plans that are very much similar to what you have on the active plan, but putting them together where we can help offer savings to organizations that have retirees. Now, one thing that a lot of people don't realize is for a senior today that has Medicare Part A and Part B, Part A is your hospital insurance, Part B is your medical coverage. When you're on the Bossier School Board or other similar organizations and you go get care, whether it's at the hospital or a doctor, you take two cards. Your red, white, and blue card, which is your Medicare card, and your Blue Cross card to go get care. And what happens is Medicare pays 80% of the bill. The 20% that Medicare doesn't pay plus the prescription drugs, that's the Blue Cross card, right? So what we're doing when you put together a Medicare Advantage EGWP that you all been talking about is we, Blue Cross, now take responsibility for administering your Part A and Part B. And we build a benefit plan so that when you go to the provider, instead of showing two cards, you show one. It would be a Blue Advantage card. We take care of managing Part A and Part B for you, and we add in what's called Part D, the prescription drug benefits. So that's MA Medicare Advantage that we've been talking about. Are we good so far? All right. So I wanted to get that out as one of the key objectives to make sure we all understood the difference between AB and what Medicare Advantage is. And a couple of things I want to point out is, as of today, there's about 17 million seniors in America that are covered by an employer group retiree health plan. Not EGWP, but retiree coverage like you have in place today. Of those 17 million, about 4 million are on a Medicare Advantage EGWP in place today, about 4 million. Nationally, there's 20 million seniors on Medicare Advantage plans, about 16 million on individual, 4 million on group Medicare Advantage. And the one thing I like to point out is about 1/4 of large employer organizations, which you fall in, already put in place Medicare Advantage plans for delivering care to their seniors. So at the end of the day, when you think about it, this program, it's just health insurance, but it's a vehicle and a tool Congress put out to American business and public institutions to help them offer the benefits that were promised, but take some of the financial burden off. So that's where they partnered with companies like ours. Now you may ask, and I think it was brought up in your last meeting, what happens if the government decides we can't pay the companies like Blue Cross these premiums to support Medicare Advantage? And it's a very good question, but it's one that Medicare Advantage companies actually deliver care and cost outcomes lower than traditional Medicare. If the government can't pay Medicare Advantage organizations, they're in a bigger trouble of insolvency. We deliver costs cheaper than Medicare. And the reason I bring that up is today when you go get care with your red, white, and blue card, a doctor, they submit a claim to Medicare. It's paid instantly. There's no immediate fraud, waste, or abuse detection. There's no medical management. There's no disease management. Bills are just paid. The Medicare companies, we are charged that if we're going to be in this business, to take care of the member, where every decision that we make and we're measured on is what is in the best interest of the retiree. We are charged with improving outcomes. So we are measured on a myriad of different items that the whole idea is how do we deliver care more efficiently and improve the outcome for the member. That's where our care is measured. So there is a difference. So that's a good thing to put in place. And to share a story, My father, many years ago, was on a plan similar to what you have now. And he didn't get the best managed care in the plan he had, but we moved him and he got onto a Medicare Advantage plan, and he had a heart condition and some other things. He was used to, I go get a drug filled, I go get my doctor visits, things aren't really coordinated. Once he got on a coordinated plan, he went from going into the hospital 10, 12 times a year to about 2 to 3 times a year. But it's where he had active engagement from the Medicare plan about wellness activities, meals after discharge. Meals after discharge are important because when you think about today's social determinants for seniors, not every senior, like my father, he was one of those that when he came home, he was by himself. Who's going to fix him a meal? So we made sure he had meals sent to his house, so that helps him get back on his feet. There's a lot of things these companies that we can offer to seniors they don't have today. It's all about improving their care outcomes. So that's what I wanted to share about what is a Medicare Advantage EGWP. Now, I did want to say, because I know we're working with ESI, who's our PBM for your commercial account with Blue Cross. It's who we use for our Blue Advantage product, but I know you're looking at the standalone RX EGWP product. There's a lot of things to keep in mind when you're looking at these plans. And just to share a few things I want to throw out there is, for example, if you put a standalone RX EGWP in place for a senior, there are some challenges that need to be thought through. It does offer savings, maybe not as much as an MA EGWP, but considerations that you need to really think through and make sure you put the plans together correctly. You will probably have a situation on a standalone RX EGWP plan where you're going to have the red, white, and blue card, the Blue Cross card, and your RX EGWP card, which means some drugs are covered under Part B, Bravo, some are covered under Part D, Delta, right? So to give you an example, insulin, it's a big problem in Louisiana, diabetes. If you go have that arrangement, what happens? Your insulin's going to be covered under the Part D Delta, which is your drug card. But the test strips are covered under Part B Bravo. So there's a coordination. So the senior goes to the pharmacy to get things filled. I got to pull out 3 cards, and we got to figure out coordination of benefits. Where the integrated Medicare Advantage plan, the EGWP that I'm talking about, it's 1 card, we take care of it all together, right? Another one to throw out there is kidney transplants. I don't know if you're familiar with this. I've dealt with this with a number of our members on our Blue Advantage plans. Who pays the kidney transplant drugs, the anti-rejection meds? It boils back to who paid for the kidney transplant. Did CMS pay for the kidney transplant? If they did, it falls under Part B Bravo drugs. If they didn't, but the health plan paid for it, it falls under Part D Delta. So there's a lot of confusion. So when you put plans in place, costs are important, but we know that all the plans that are being shown show a lot of good costs. But at the end of the day, the value you need to look at is going with somebody that you know and trust, somebody that's going to give you the guidance and has the background and experience. We can give to you after this meeting. I have referrals, and one I think is very powerful. I started working with Lincoln Parish School Board about this time last year, and we met with their insurance committee, then the board, and then we rented out the Ruston Civic Center and brought in all the seniors. And we moved them to the full MA EGWP, all 521 on January 1. And we were run through the ringer on that installation. We've not had really many phone calls on that. And Dr. David Gillette, I don't know if you know him, I can connect you with him. He ran us through the ringer with, I don't know, 50 some odd questions. It was like 10 pages. He kicked the tires. He's not only a school board member, he's a spouse of a teacher, so he's a member on the plan. Recommend reaching out to them and talk to them about their experience on a similar plan that we're proposing to you tonight, that they've got a very good experience with the team, and group Medicare works different with the hospitals than individual Medicare, and they can talk to you about the local hospitals that they come over to Shreveport all the time, and we take care of them. But it's a group that you should talk to when making the decision to really get an understanding of what they were considering, because they're facing the same challenges that I remember when I was sitting in the meeting. I forget which board member said, our number one mission is the children, and our budget's getting crushed. How do we solve this problem? And that's where the MA EGWP came in, because it offered such substantial savings. but it also ensured because they took advantage of Congress's tool. How do we help you take advantage of that to make sure we protect our seniors and honor our promises, but at the same time, make sure we have the money to take care of educating our children? That's it at a high level.
Thank you very much. I'm going to open it up to the board first. I know this is Insurance Committee, but anybody on the board that has questions, we'll start there. Anybody want to take the first swing? Yes, sir.
I have Medicare, I'm retired.
Mr. Dean. Mr. Dean.
My question is, why do some of the hospitals or doctors not want to take Medicare?
So, a lot of doctors, how to put this, there's a myriad of reasons that doctors don't want to take Medicare plans, but there's also a myriad of reasons they don't want to take commercial plans. It's easier if they can get paid directly from CMS and there's no medical management, no disease management. And at first that sounds great, and I'm the biggest proponent of Medicare after seeing what my father experienced. When he had instant care, bill CMS, life is good, but when he's in the hospital all the time, that's not good. But when he got into a managed care plan where you had nurses reaching out to you, making sure there was programs put in place to get better outcomes, I would rather have him work with somebody that wants to ensure the better outcomes. Not saying doctors aren't good, but the reason you have this integrated system in place is the whole core is how do we improve your member experience and outcomes? We get penalized, and we have reports where we monitor any dangerous rapid discharges from hospitals. We are charged with, as I said, focusing on getting the best outcomes. Now, the plan we put in place is different from individual. And what I mean by that is we've got a passive PPO. So when you think about traditional Medicare, if a doctor takes Medicare A and B today, forget network. If they take that type of plan, they would take our plan, and here's the reason why. On our group plan we're proposing, the 100% out-of-network benefit makes it passive. It operates just like a traditional Part A, Part B with Medicare supplement. So there's no issue with the doctor saying, I don't want to do business with you. They don't have to worry about the challenges they think they're facing. So there's no red tape. There's no objection for a member to take this plan. Yeah.
I understand that's a great answer, but why we have doctors, Willis and I, that do not want to accept our Medicare Advantage? So
But it's not all Medicare Advantage because they actually take our Medicare Advantage on the group side. They actually do take it. That's why I said, talk to Lincoln Parish. They actually use Willis. Willis has no issue with our group plan. Individual is different than group. And we could talk, I could get you into the weeds about the difference between individual and group on how they pay and how they operate. There is a difference. And when you call Willis and say, what do you think about Medicare Advantage? They're answering from the individual perspective. They're not answering on group. There is a difference, like I talked about, why we build the plans called waiver plans.
Billy.
Okay. I wasn't going to say anything. I have also heard a lot of stories opposite than what you're telling that are on the Advantage Plan, group Advantage Plan.
Okay.
That haven't been good. But my question is this. You mentioned that this is subsidized by the federal government, correct?
Correct.
What's going to happen, which I don't think I got an answer a few minutes ago, in a few years, if the federal government chooses not to subsidize this anymore, what's going to happen to our retirees at that point?
If the government decides they're not going to subsidize it, it means they're insolvent. And here's the reason why. We deliver this at a lower cost than a senior staying on traditional Medicare A and B. That's the difference. So it would cost the government more money to turn this off. But if they turned it off, it means they don't have the money to pay their own bills. It would not make any sense.
Okay, thank you.
Well, I've got about a dozen questions, so if nobody else is going to take a swing, I'm going to take a swing. I mean, I know you said you don't want to get into the weeds, but
Depends how far you want to go and.
Well, let's start with getting in the weeds. I've seen pictures from Willis Knighton who you say accept it, yet there's a picture in their lobby that says beware of Medicare Advantage.
Correct.
So how am I to make an informed decision when who you're telling me accepts it has a placard in their lobby in several
Correct.
different places that says beware of Medicare Advantage?
Fair question.
Thank you. I thought so.
And I appreciate it because I want to, let's just get it out on the table. So when you look at a Medicare Advantage plan for individuals that you see every fall, the TV campaigns, right? You all see the TV campaigns and all the advertisement? That's what they're talking about, and I'll explain why. If you are a senior who did not work for a great organization like Bossier Parish or other ones that have retiree benefits, you're Joe Average American, you don't have a group plan. You have traditional Medicare A and B. If you don't buy a Medicare supplement, just bear with me, to subsidize the 20% that Medicare doesn't pay, you get sick, you pay. Did you all watch Toy Story? Did you ever see that movie? Buzz Lightyear? So when you have traditional Medicare A and B, you pay 20% to infinity and beyond. There is no cap on your out-of-pocket. That's true. So when you look at an individual Medicare plan, if you don't have the money to buy Medicare supplement, individual Medicare plans are good, but they do have things such as a max out-of-pocket. And if you look at the plans on the market, the normal max out-of-pocket in North Louisiana is anywhere from, I don't know, $5,000 to $6,700 for the medical part of the benefit, your max out-of-pocket. So for Willis Knighton, a lot of people may not have that $5,000 or $6,000 if somebody gets really sick to pay that benefit. They want it to be the Medicare A and B with the Medicare supplement, and it comes through and they get paid 100% right up front. That's the big differential. Where on group plans, you've got a benefit that if I was reading the slide right, you go in the hospital, it pays 100%, you go to the doctor, it pays 100%. The group plans operate different. The group plans, Willis gets their money. There's no worry about them not getting paid because they're going to get paid the same Medicare rate they get, whether it's on somebody on traditional A and B or on our group PPO plan. They get paid the same amount, but they're not going to have to chase down any extra money because it's 100% benefit. That's the big difference.
Mr. Wiggins has a question.
Thank you, Mr. Chairman. Sir, I've been on the board a long time. I received about 300 calls in Texas with people that are unhappy with the prospect of going with Medicare Advantage. Many of them did some background checking.
Is because what?
Many of them did some checking on what you do, and they're not happy with what they heard. How can so many people be wrong and you're right if you've got a better system we've got now? They don't want it.
I am not always right, but I will say this. Everybody has a different experience, and the details actually matter. There is, as I've said, there is a huge difference between an individual plan and a group plan, but there's also a huge difference between having traditional Medicare and a Medicare supplement, and you don't have any integrated care. You get to go to the doctor anytime and do whatever you want. Doesn't mean you have the best outcome. Yes.
Let me ask you. People that have spoken to me, the ones who have checked on the veracity of your company, they say it's a great company until you get sick. And once you get sick, you've got problems, insurmountable problems. Whereas with this tried and true program that we've got, it works very well. Thank you.
Well, let me just answer a question to give you an idea about claims. Another measurement that's the Centers for Medicare and Medicaid hold us to. Our June 2020 report for the government segment, which is my division. We have clean claims submitted that are in 30 days. The CMS requirement is they're paid within 95% within 30 days. We're at 97% through June of this year. Claims paid in 60 days. The CMS requirement, 100%, we're at 100%. So claims are paid. Claims are paid extremely quickly. Now, I think there might be, concerns, questions, differences between an individual and group plan. Number one, which I've already articulated on Willis Knighton, so that if somebody has a concern about their experience or their out-of-pockets on individual versus group, there is a difference. But there's also a difference on some people are more open to working with managed care and nurses and doctors reaching out to you about, we saw you've been in the emergency room over 3 times in the last 90 days, where we're reaching out to find out, is there some social determinants? Is there something going on, you're not getting the right medicines, the right care? We're taking an active role. Not everybody's going to want to be involved in managed care. Our goal is, how do we improve your outcomes? And like I stated, CMS charges us, the government charges us as an organization. Our focus is the best interest of the member in all of our decisions for approving medical care, managing care. And it goes back to the philosophy of the Louisiana Blue, which is to improve the health and lives of our fellow Louisianans. That's our goal. That is our goal.
Had a question, Mr. Bullard?
Thank you, Mr. Chairman. Sir, a couple of comments and then a couple of questions. First of all, please do not misconstrue our comments and questions, and I guess you could say some of it may borderline be a little criticism, because everyone is very pleased with the job that Blue Cross Blue Shield does. Everyone wants to stay. That's
Correct.
What the
No, I get it.
concern is. We want to stay with Blue Cross Blue Shield. But as Mr. Wiggins indicated, I find it hard to reconcile in my mind the divergent opinions and information that's being shared with me. I come into this room and I hear one set of information and facts. I go home and I hear from other individuals who claim to have done due diligence, and there's a lot of conflict there. One thing that caught my ear just a moment ago, you talk about how well you pay your claims. You meet the criteria for payment of claims. This may be where we have a little misunderstanding. It's not a question of whether you pay it, but do we even get to the point of a claim because there was not an admission? That is, someone got sick, and under Medicare Advantage, they were basically turned away, be it after an extended stay or whatever, because we have been told, not from you, I cannot verify the veracity of this information, but have repeatedly been told, if you get really sick, there's going to come a time when Medicare Advantage is going to leave you, the old saying goes, naked and alone.
It's a fair question.
You're going to be out there by yourself.
Yeah.
Now, you pay your claims, no one questions that. You
I understand.
work for a premier organization. We all accept that.
Yes.
We'll all sing your praises here.
I
But
appreciate, yeah.
what about, maybe we don't get to the point of a claim. Maybe some of these stories are about people who, they were turned away.
Yeah. So it's a very good question, and it really hits home with me. And the reason it hits home with me is, I'll give you a quick backstory on why this is something I take near and dear, and I'm very passionate about what I do. My grandfather was a person like myself in the insurance industry. His daughter, my mother, was a school teacher. My grandmother was a school teacher. My mother worked over 30 years for a school system. Her school system started out on a company called Indiana Blue Cross, similar to Louisiana Blue Cross. As they grew and grew, we went from a fully insured group that only had 3 schools, an elementary, a junior high, and a high school, to a very large system. and they went to ASO, a self-funded arrangement like y'all have here. Then they ended up leaving Blue, and they went and started tearing it up where they had an administrator in one state. They had a medical management firm that approved, can you get care in another state? Reinsurance in another state. Long story short, this is all happening by the time I'm in college, and then I come to Louisiana in the 90s. Anyways, by 2008, my mom's entered retirement. She got a blood illness from the side effect of a medication. The company, or that organization, they tore the whole plan apart and just vendored it 7 ways to Sunday. She got sick. To fix that illness, she was in the hospital 6 months and ran up a $995,000 bill, which sits on my desk in Baton Rouge as a reminder why I do this. The school system did not tie everything together correctly. Reinsurance, all of it. They denied the claim to protect the integrity of the plan. My parents, until the day they died 4 years later, they were suffering to try to pay to keep the roof over their head. So I take it personal because her system, though they meant well, they made the wrong decisions and left her out to dry. When I liquidated my family's estate, I got nothing. So I take it personal. So we do pay our claims, and it is a premier company, but more importantly, when you get sick at Blue Cross on this plan, it's just like the plan you're on today. It's just health insurance. It's a vehicle designed by Congress to help you all out, not just financially, but charge the companies that want to do this, that we have to meet certain measures for member satisfaction. We get penalized if we have somebody leave the hospital too soon. You know what happens? It hurts us. We are measured by the government. So your commercial plans do not get the same oversight that CMS puts on Medicare companies. We get measured, we get audited annually, various audits. We have to report measurements from simplest things as breast cancer, colorectal cancer screenings, annual wellness visits, your statins, what's our drug adherence, what are we doing with opioids, did we have dangerous discharges where somebody was discharged from the hospital too soon, to get to your question if you're sick. We are measured so many ways that the whole focus is the best interest of the senior. That's what we're measured on all the time. And I know there's horror stories because I just told you one. I lived it. It's on my desk in Baton Rouge. I don't mind sharing it. $1 million bill. That's why I'm passionate about this, because I know what it's like to have your family financially ruined. Been there, done that. So I don't take it personal. I find it good to have hard conversations, and that's why I said talk to Mr. Gillette over in Lincoln Parish. If you think that's hard, he put me through the ringer.
Real quick, first of all, hello to everybody at home watching, but I've gotten some feedback. Board members, if you can, pull down your mask when you're speaking and speak into the microphone. They're having some difficulties hearing the questions once we ask them. President Bamberg, you had a question.
I've talked to a lot of folks, and to be honest, when they brought this plan, it's something that I wanted this to work. The way that everything that looks on this paper, but we get some questions, and one of the questions I would have is, you mentioned that you manage these patients medically.
Yes.
Okay? And I understand that you see a downside to I'm gonna write this as a Medicare to my Medicare patient as a doctor. I'm gonna write it. It's gonna get approved and get paid.
Yes.
And you're gonna medically manage these patients. Okay. So my question is, I'm sure everybody here and watching, they think their doctor has their best interest in mind, and their insurance tries to save money. That being said, when the doctor says, you know what, I really need you to go have this test, and it's very important, I need you to go over there today and get it. And Medicare says, yes. Does Medicare Advantage say, wait a day, wait 2 days, wait?
Yeah. So
let me make sure that reach our goal, because the thing that concerns me is that's a long 24, 48 hours.
Correct. So are there checks and balances, just like you have in your commercial plan? No different. there's always a checks and balance to make sure, is that appropriate? Does that make sense? Your doctor, and to everybody listening, your doctors do have your best interests at heart, but to use my father, who was a heart patient, at one point in his years of post-open heart surgery, there was one point he was on a dozen meds. What we learned with my father, not every doctor talked to each other. So a doctor may say, I need to put you on this med. What is it going to do to the cocktail med you're already on? So that's where when you have the integrated plan, we hopefully have some oversight. But to answer your question about, I need to get that MRI for my patient, we're not going to stand in the way of getting the MRI. Now, if they're ordering an MRI for something does not make medical sense, that's generally accepted medical practices, that might, raise some eyebrows and concerns going, hey, why are we doing this? But there's going to be checks and balances to make sure it's appropriate care and making sure that a doctor may not know everything that we see because, again, not all doctors talk to each other.
Okay. I'm also a heart patient, so I can promise you every doctor I go into, you either bring your bag of medications or you bring a list of medications.
My dad did the same thing.
So I bring my pill, I have a pill box probably like a lot of the people in here have that I take every
Yes.
day as breakfast. And that's just a little concern that, I don't think my doctor is mismanaging me because he's giving me a cocktail of
So
drugs.
the best way to think about it is this. Is the school system going to let a doctor just start writing to have you send 200 of the members of this group to go get MRIs if it doesn't make medical sense? The answer is no. The Medicare Advantage is no different. We're not calling up Uncle Sam to say, can you go get this done? We're managing the plan on behalf of Medicare, and we're applying the same types of standards you're familiar with for managing the care. It's just it's on a different vehicle. So if you need that and it's medically necessary, you will get that.
Okay, thank you.
Well, Mr. Cheatham, then Mr. Dean, or Mr. Dean, then Mr. Cheatham.
What if the doctors are,
Mr. Dean, microphone.
what he was saying, do y'all have a doctor that has to approve what the doctor here asks for?
Depends on the item, like your commercial plan. If there's something very expensive, there could be some approvals required, but we have, again, you're working with Louisiana Blue, one of our key doctors that's involved in this for high-level care, not routine care. MRI is routine. But if there's something that needs quick, high-level approval, one of our doctors on the government program, she's based right here in Shreveport. But we're also based in Baton Rouge, and our back office for Medicare Advantage is in Monroe. So we are very, very local, and we're very, very responsive.
But I guess the question kind of was asked earlier. If your doctor disagrees with my doctor, what happens?
They file an appeal, and they're going to get a pretty quick response. I had somebody on an individual plan filed an appeal. What did today's? I think it was Thursday last week, and the agent called me up, and by Friday it was rectified. So it was like less than 24 hours on an appeal, and it wasn't for a routine item. It was not for routine. It was something more severe, and once it went through the first check by our medical staff, it was taken care of. But this is the same thing you'll experience on your active plan, is the same thing.
Okay. Mr. Cheatham.
Thank you, Mr. Bass. Y'all are gonna have to apologize because I'm gonna take y'all on a full story and it's gonna be long-winded. But I believe it's gonna end up somewhere that's gonna make everybody in this room really happy. I got on this school board 5 years ago. I wanted to make a difference in South Bossier. I wanted to make a difference for my son who was starting kindergarten, my daughter who was in our school system, Roy Underwood, who is my cousin, this man sitting on this front row right here, Mr. Bobby Marlowe. I love Bossier Parish and I love our school system. Always wanted to be a basketball coach. Thought I was going to be a coach and a teacher. Business things took me other directions. But I got on this board 5 years ago. First year, full year I was on the board. I was asked to be the insurance chairman. I was like, woohoo, know nothing about insurance. This will be real interesting. So I met with our consultant 1 or 2 times during that year and talked to him, and I said, man, we spend a lot of money on insurance, a ton of money on insurance. And as we visited, he said, you know, I feel like we get the best deal we can get with Blue Cross Blue Shield. Feel like they take good care of us. I walked out of his office and said, cool. This is my consultant taking care of us. I moved on. About a year and a half ago, I was challenged with being president of the school board. During that time, I was challenged with going in front of the community and trying to get our teachers a pay raise. When I tell you that year was probably one of the toughest I've ever had, sitting in front of casino bosses, managers from Vegas, here, there, and they yelled at Mr. Bamberg, Mr. Downey, and myself about us trying to get a teacher pay raise. Took it from them. I took it from the Lions Club when we went there. I took it from the Bossier Chamber. I took it. I got threats about my business. All I was trying to do was do the right thing. I didn't cave to those business people. I said our teachers deserve a raise. And again, I apologize that I'm taking you on a long ride here, but I want you to understand, after that teacher pay raise fell, I had someone come knock on the door at my office and say, I think I know how we can get the business people to help support y'all if y'all have to come back and do this again. Y'all got to show them y'all can save some money. And I said, I'm listening. He said, I think I can save you $2 million on insurance right now. I said, I'm listening. And so I then set him up with our insurance consultant, our superintendent, our CFO at the time. They had a meeting. I was not a part of that meeting. Not real sure why I wasn't a part of that meeting, but it might have been something that I had going on. After that meeting was held, I was told it wasn't a good idea. We don't need to move forward with this. And again, okay, it's not a good idea. I will tell you that 2 days ago, upon my research, not upon some document that Willis Knighton sent out, not upon some document that Blue Cross Blue Shield sent out, I did my own research. And I found 3 ways that I feel like this plan would negatively impact Mr. Marlowe, Mr. Krudoff, his wife, and the people that helped raise me to be the person I am. And at that point, just like I said at the last meeting, if there was one thing that negatively impacted any of these retirees, I was out. Unfortunately, due to no fault of anybody sitting in this audience, but unfortunately, due to fellow board members saying that Mr. Michael Guyton was going to finance my city council campaign if I got this pushed through, because he was going to make $300,000. This was shared on a golf course with some other retired coaches. Not once, but twice during this process of trying to save money for our taxpayers and our school system and get our teachers a pay raise, my character has personally been attacked. So think about how mad y'all are that you heard we were going to change your insurance. And that's kind of how I've been for the past week. But I've still answered phone calls from Mr. Krudoff, Mr. Marlowe, about 115 calls, emails. I didn't get back to everybody because most of those calls were 51 minutes to 53 minutes long. I don't know how long my other board members stayed on the phone talking to each of you that they talked to. But I wanted to do my best to make the person that I was talking to understand why we were even looking at this. Okay, we were told just a week ago there would be no loss in benefits. Everything was the same. I was told that by our consultant and told that by a salesman. But it's not the case. from what research I have done and some others. So I say all of that and took you down a long road. There's not a board member up here, and especially the one, funny, the camera got moved and it's behind my back. Okay? Camera's been on my back for about 2 weeks. There will not be a motion made by me or anyone on this committee tonight to change to the Medicare Advantage plan. But what I will ask of my fellow board members and the retirees is that the next time we sit down to visit about an insurance, that we don't have board members and retirees that just jump and say no without doing research. We have to. Our job as a board, I said this to somebody earlier, and Mitch Downey gets tired of hearing me say it. Right? I got 2 jobs as a board member. I don't hire a coach. I don't hire a teacher. I don't hire a bus driver. I hire and fire the superintendent as a board. And I'm supposed to manage the money, the taxpayer money, and make sure it's spent on our kids, on our teachers, and on our retirees. We all need to work together. I got accused of having some financial deal in the game to this, folks. I sell real estate, and I grind for every dollar I get, as well as most of you have always done all your life as well. So I say all of that to say we are one team. This meeting, everybody, there's 207 people watching this video on YouTube, which, by the way, I'll pat myself on the back as the camera's patting me, watching me. This is live on YouTube because what I did 4.5 years ago, because I wanted this board to be transparent. A lot of talk for years that this board wasn't transparent. We're transparent. 204 people were watching. Now that I started talking, probably 150. Probably tired of hearing me talk. But what I say all of that, and I thought it was important to understand that we have to work as a team. Okay? Every board member, the last meeting we had, I believe, if not every board member, 5 or 6 said, if this negatively impacts retirees, we're out. But by the time it got around town, I was getting a cut. Michael Guy, did you know you were going to pay me if we changed this tonight? I didn't know that either. Michael Guy, did you know you were my best friend? Michael Guy, me and you best friends? Oh, yeah, best friends. I graduated with your sister from Parkway, a few years younger than me. We went to church together. When was the last time you saw me before you knocked on my door and tried to save us $2 million? Okay. So, again, I'm ranting, and I'm sorry. But I'm telling you what we were trying to do. And by the way, this last time, so remember I said last year, they said we couldn't do anything. I went away and they came to the new insurance committee person. So I didn't even have anything to do with them coming back to Mr. Adam Bass. But all that said, I felt like everybody listening and in here needed to know why Shane Cheatham, why we're even having this meeting tonight. But if at the end of the last meeting, if it would have been communicated properly, y'all would have never gotten upset, fired up. Mr. Krudoff wouldn't have told me Mr. Krudoff gave me a little bit, y'all. Mr. Marlowe gave me 3 licks in 7th grade. I thought I was fixing to get them again. I wasn't, and I'm going to be honest. I got fussed at. The first lady that fussed at me sitting up in the top corner, looking pretty in her maroon and purple. And that conversation was 55 minutes. But I tell you, I'm not scared to make a tough decision if it was right for y'all. Now, obviously, you didn't think it was right because you don't like change. Then people start spreading stuff around. Then it was a total nightmare. And I don't believe this plan is a nightmare, but what I do know is I found 3 things. Co-pays, in some cases, were more expensive. That negatively impacts you. I didn't like it. Managed care, they talked about that a little bit. I think everything at some point is going to be managed care. So if we're not changing now, we're going to change later, down the road. Might be after I'm gone off the board, we've got a whole new board up here at some point. I think that's going to become the norm. Family Doctors doesn't accept it, is what I was told. I think the Caddo Parish Sheriff's Department sent that to us in an email. That was the only doctor in town that did not accept this plan. That's a negative impact on these retirees. I'm out. It was that simple. So I hope, and I believe every board member sitting up here has y'all's best interest in mind. And I hope y'all understand why we did this. It wasn't because of what you heard. Somebody had some financial gain. It was because we've got to do the right thing with our budget. We just voted, I voted no, we voted to approve a negative deficit budget for next year, $2.6 million deficit. We can blame it on COVID. That's fine, we can blame that. We can blame it on the tax assessor giving a property value break to commercial businesses, which they probably needed in these times. But what I'm going to challenge this board with, and funny, it's the same thing that the business community challenged us with when I went and was telling them why our teachers need raises. And they said, the first answer they give you is you got too much dead weight up top there. All your money's up there and you're not spending on teachers. Well, we went and we checked that out. And compared to parishes our size, that's a false statement. So it's our job as a board. We go through our budget and we look at things. And there are going to have to be some things that change. We are losing teachers left and right to other parishes because we can't pay them. I believe that our current Blue Cross Blue Shield plan that we are on charges us too much. Believe they need to trim their pencil. I had hoped that even having these conversations about this would help with that. And maybe they will, because maybe they know we're serious. Or they can just somebody can go around and spread some bad juju about it and get everybody fired up, and then a lot of board members are like, whoa, whoa, whoa. We don't want to make them mad. I don't blame them for not wanting to make y'all mad. Y'all have earned every bit of what you get. But I also tell you at the same time, and somebody's probably tapping saying clock, stop talking. Help us figure something out. Maybe we all go sit at Blue Cross Blue Shield here in Shreveport and we knock on the door and we all 1,200 retirees, 12 board members, active teachers say, save us some money so we can spend it on kids instead of insurance. Maybe we get fired up about that. Just something for us all to think about as 200 of us watch this, several hundred in here. Our job, it's no longer y'all's job because y'all are retired, but we'd love to have your help. But it's our job as a board to educate kids, keep and retain and hire the best teachers, and take care of our retirees. I asked the board to continue to look at insurance options, to continue to push, to have a consultant that pushes with us to save money on insurance. 89.1% of our budget goes to salary and benefits. There's nowhere to cut money on the other 11%. There's not. We're not overstaffed. My hardcore Republican buddies that are watching this, okay, we're not overstaffed. If you want to come sit down and let us show you where we are compared to other parishes, we'll do it. So I'll stop preaching. And I'll tell you that I'm sorry all of you had to get fired up and be here tonight. I wish it wouldn't have happened the way it happened. But I also want y'all to understand why we are here tonight. And it's because, one, we want to protect y'all. Just like I said, Mr. Bamberg, Mr. Bass, Mr. Bullard, several others at the end of the last meeting. I don't know if anybody watched that one. But at the end of that meeting, we said if one thing negatively impacts our retirees, we're not going to do it. And I'm here to tell you I found 3 things. And I was the henchman, according to everybody on this. I don't like my character being called out, and I apologize if I'm offending any of you. But everything I've done for this board, everything I'll continue to do for this board, And everything I try to do in my life is because of the character I have, because of the people that raised me, like Roy Underwood, Mr. Marlowe, Ken Crudoff. Miss Haga, she called me, my 5th grade teacher. She wasn't happy with me. But I promise you none of it was done to benefit Shane Cheatham or anybody on this board. It was done to benefit the children of Bossier Parish. And if, and only if, we could do it without hurting y'all, we were going to make a change. But we found out that it would hurt y'all. And based off that, we're not making a change. And I'll turn the mic over.
Anybody want to follow that up? We were required to make sure that the questions that were submitted are read and answered. So if I can at this time, Ms. Bales, I'm going to ask, since the experts are here, I understand those questions were submitted and we have to read them into record. I'm going to allow that to happen so the experts can answer it. Yes, sir.
Mr. President, the law doesn't require you to read all those in if there's not going to be a vote here tonight.
Okay.
If you could attach them and we could print them and attach them to the minutes if you preferred. Or,
Okay.
But I just want to be clear that the law would not require you to spend the time to read all those in.
Okay. But I do not want to cut off anybody who came here to speak either. And I know there's a lot of people here that did come to speak. I know Mr. Cheatham ended. I didn't hear a motion or anything in there, but I am not going to cut off anybody because Julie Dupree, who is my 3rd grade teacher that used to whip me, is sitting there, and if I cut her off, I'll have to be in the corner again. So I don't want to cut anybody off. Does anybody have any questions, concerns, anything that they'd like to discuss?
We do have several people who filed request slips for public comment.
Okay.
And if those individuals would like to still speak, we can queue up the first 5. The first one being Kim Gaspard. And if numbers 2 through 5 would please form outside the BIC auditorium, we're going to have them come to the podium separately.
Mr. Gaspard, you have the floor.
Chairman Bass, President Bamberg, Superintendent Downey, board members. I'm very emotional right now because let me just say to Shane, you're a much man. You really are. I know Bobby Marlowe and I know Ken Crudoff very well too. I'm going to forget part of my delivery tonight because I want to say something from the heart. Bossier Parish started this insurance program many years ago when Jack Gillette was the finance director, and the governor came into town and wanted to know how he was doing it. And at that time, they took monies in addition to what state monies were and formed the first plan for school employees in the state of Louisiana that was not state insurance. Since that time, you have seen the Bossier school system excel in so many different ways. We have over a 90% graduation rate right now. And it's on your watch. And I commend you for that. Okay? And I certainly cannot blame you for trying to be fiscally sound. But folks, last year, the Medicare enrollees from Bossier Parish saved the Bossier Parish school system by being on Medicare. And I might add, they were mandated to use Medicare if they could. they saved the Bossier Parish School Board $16,533,000. Now, I don't know any other way to say it that our shoulders were getting pretty heavy too. Why? Because my wife and I, prior to being on Medicare, were paying $135 a month for health insurance with Blue Cross Blue Shield. Today, by being on Medicare, we pay $310. And we are the bottom. We are the ones that don't, that's the minimum that can happen. So we have more than doubled what we pay monthly for health insurance. And we've saved the parish $16 million, almost $17 million. So to be, for many, many years, the one thing that you can say about our school system, people would say, oh, we need to hire from outside. We need a superintendent from outside. But you know what? Every year, principals are hired from within. Assistant principals are hired from within. And then our superintendents come from here. And what's the result? 94% graduation rate at some schools. You bet it is. That's great. But never before has one subgroup been singled out with regard to insurance. Okay, we can talk about the promise that was made, that you all are aware of that, but never before has one subgroup been singled out. If we want to go into all the research we have and talk about health management systems, I don't really think that's appropriate right now, after what you've said, Mr. Cheatham, because I have to hand it to you. You stepped up. I would like to make a recommendation because I have it in writing right here, and I want to let everyone know that I didn't tell Mr. Cheatham what to say, but I would like to propose that a committee be formed that would be several members of the insurance committee, members of the central office staff, as well as members of every subgroup of insurees in the parish. Now, I learned a long time ago that you don't go to the debate or you don't go and argue something unless you have a plan. Mr. Haynes always taught us, always have a plan B. Well, I'm coming to the game today because I know that those plans are out there. And if we can involve all of the subgroups together, then you now have retirees and employees who feel value. Feelings got hurt on this, no doubt about it. But there's there's one word that really comes up that fits this whole situation. Fear. Fear. If you don't think these people on this plan right now that are 85 years old are not mortified by what could possibly happen to them, then you're wrong. And I'm talking about real fear. There's two perks if you're in the Bossier Parish school system. You're not in it for the money, obviously. But there's two things that really, and I'm sorry if I'm emotional again, there's two things that we have to hang on to. One is that we have a good retirement system. And two, the Bossier Parish school system has always taken care of us. As retirees, they have been our lifeline. Bossier Parish schools are family. I say it again. From employees right now that are active employees, to Blue Cross Blue Shield retirees, to Medicare retirees, we have and always have been family. And that is why we are the Bossier Parish school system. that is why those scores are where they are, because those keys were handed to all of these different generations of educators, and they have made it better every generation. And I'm so proud that I am from the Bossier Parish school system. I'm sorry. I will say this about Advantage Medicare, because that's the first time I've said it tonight. And I came here to argue it. It may very well be where we go to one day. I hope not, because I like flexibility in a system, and I have, I may not look like it, but I'm broke down. Okay? There are a lot of us here that have some medical situations. I shouldn't be here right now. I've gone through 2 pulmonary embolisms, and if Xarelto wasn't available, I may not be here now. And you know what? That's a blood thinner that's not covered by Medicare. But the Blue Cross Blue Shield Bossier Parish drug plan does cover it. There are horror stories out there, I'm sure, that I could give you some. But the mere fact that there would be a chance that a person could lose their doctor that has been with them for 3 decades or more is frightening. If something happened and Dr. Bruce Henderson, who is the glaucoma specialist in this town, was not available to do the 5 procedures that he's done on my eye due to glaucoma, and I did not have the great insurance I have right now, I would be up a creek. If those Willis Knighton doctors had not diagnosed 2 pulmonary embolisms in me, I wouldn't be here right now. But for someone to come and tell me, well, I'm sorry, you won't be able to see those people any longer because we have a group of doctors that we have over here that you're going to have to see. I'm sorry, but it makes me sick. So again, Shane Cheatham, we've never sat down and talked, but we will, because I'll probably be at your office one day next week to have coffee and really tell you what I think of you. You're to be applauded. I'm sorry we got to here. Okay? I'm sorry we got to this point. But everybody in here and everybody up here is very thankful for the Bossier Parish school system. And I want you to really understand how much they love it. Lord, I've got 5 grandkids going through it right now. And they wear me out every day. I'm tired of buying Google Chromebooks. But please understand, Shane, I know how you felt now when you were singled out, because we've kind of been singled out. Okay? And those figures I gave you indicate that we've carried a big brunt of that. At the same time, if you ask our insurance people, or even Ms. Bamberg, who was very kind to furnish me some information, if you'll believe me when I say, that senior moment just hit. Well, they may not make it yet. I don't know. I have rattled on enough, but I do thank you for getting ready to do what I think you're going to do. Okay? Because we love the system. This was our life.
I want to make sure that I say this. Again, I don't want to cut anybody off, but there has not been a motion here made to take an action on Medicare Advantage. Mr. Gaspard, that was very poignant. I want to thank you for that. The only thing I will say, and I think you've seen the agenda, there are things that are being looked into tonight that address all subclasses, active, retirees, and others. So I don't want you guys to feel like any one group has been picked on. because I think you guys have felt that way, and I know this board feels the same way that Mr. Gaspard does. I am going to recess for about a 5-minute bio break after Ms. Bales gets a chance to speak. Again, no motion was made. Medicare Advantage does not move forward without a motion being made. I do not want to cut anybody off, but I just want to make sure everybody's clear on nothing moves forward if there's no motion made. So again, if you want to speak, you're here to speak. But if for time's sake, with COVID and everybody being in this room and being close together, we'll have an opportunity. But one second, I'm going to allow Ms. Bales to speak, and then I'm going to open it for board comment, and then we're going to take a quick 5-minute bio break.
May the minutes reflect that Mr. Gaspard had the proxies of 16 retirees for him to speak on their behalf, and we'll enter that into the public record. We do still have others who do still want to speak. They understand that no action is being taken tonight. So would you like to take that break first?
If we can, everybody will have an opportunity to use the restroom, do what they need to do, and then we will come back. I want to take this opportunity to thank everybody that has come, because between what Mr. Cheatham said and what Mr. Gaspard said, I think there's no question at this point that everybody is in this for the right reasons. So we're going to take that short break now, and we'll be back at, let's say, 8 o'clock on the dot, 8:00. Okay, guys, we're going to bring the meeting back to order if you'd like to. Please take your seats. We have comment cards here, those that wish to speak. Again, I don't want to cut anybody off, but I'm going to read the names on them. If you don't, raise your hand if you're not here, if you don't wish to speak anymore. If you can tell us that, we will happily, but we want to make sure that if you want to, you get an opportunity to. So I'm going to go through the comment cards.
We may want to give them some time because some of them are in different parts of the building.
Okay, all right, we will give them some time. The first name I have, which I just socially distanced and hugged her neck, so I don't get accused of anything, is Miss Jan Hollis Abendroth. Okay, thank you. I have Miss Mickey Rohr. Would you like to speak, Ms. Rohr? Okay. Ms. Rohr, it's a 3-minute. I'll be timing you. I'll raise my hand as you're getting close to the 3 minutes. Please have the microphone.
It won't take me 3 minutes. I'm speaking on behalf of the bus drivers, retired bus drivers and current bus drivers. I've checked on this. I've had people calling me all week, and even people that within the next 5 years will be retiring have called me. And so I wrote the things that I was concerned about. One is so many of these won't let you use Willis Knighton. Most of our, and I know Blue Cross Blue Shield doesn't have that policy, but most of our doctors that we use, the retirees, is in Bossier Parish, and we use the hospital. Some of the procedures have to be approved before you can have them. You could die before they approve it. Because sometimes they take too long to approve it. It's not always the next 24 hours. And we were told at the last board meeting that if we didn't like this, we could go back to Medicare and Blue Cross Blue Shield the old way. I was told we couldn't. The people I checked with said no. So we would be up a creek, the retirees especially. I think that bus operators, professional bus operators, are left out of a lot of things. They're as important as the teachers. If we don't get them there, they can't teach them. And it's the decisions that they've made about the first day of school is not working out. There's been too many problems that nobody had an answer to. I had one call me and said that
Off, but we're talking about insurance, and so
I know,
if we're
but
going to get
this-
into the opening of first day of school, that's for a different day, different topic. So we just need to
okay,
make
but
sure we hold the
it needs to
topic.
be addressed because the
Yes,
answers
ma'am,
aren't
but
there.
that'll be a different meeting. I'm sorry.
Well, no one that called me, or no one I've talked to, has been in favor of this. I know we're older and we're set in our ways, but what we've got, we know. What's out there, we don't know until we try it. So my people don't want it changed. Thank you.
Thank you very much. The next person that we have that would like to, that filled out a comment card is Michael Schultz. Is Schultz still here or in any of the other rooms? He declined? Okay. We have Miss Barbara Rudd.
She turned in her number.
Okay, so she is declining. We have Miss Patsy McGirt. Is she in another room?
Everybody's in this room now.
Okay, so Miss Patsy McGirt. Judith Miller. Okay. Kathleen Johnson. Susan Alexander. Okay, thank you, ma'am. Margaret Seaball. Annette Lee. and Ms. Sharon Parrish. Okay, there are several people that I'd like to thank in this room that I was able to even read those names off, so thank you, retired teachers, for teaching me how to actually read, many of you. So that would be the end of public comment. If no one else has any comments they would like to make on the Medicare Advantage that was just presented. Okay, I would entertain a motion at this point. Ms. Brotherton? I'm sorry, Ms. Sonia? Ms. Bales?
We just also need to note for the record that we extended the opportunity for our retirees and our employees to submit their questions or their comments electronically, and so those will also be entered into the record.
Okay, thank you very much. Ms. Brotherton?
Well, after much discussion, clearly the retirees do not want to change their insurance plan at this time. So I would like to make a motion that we do not go forward with a Medicare Advantage plan, and we allow our retirees to stay on their present plan that they have now with no changes. They are now on Medicare with Blue Cross Blue Shield through the Bossier Parish School Board as their supplemental plan. Thank you.
Okay. Second. We have a motion by Ms. Brotherton, a second by Mr. Cheatham. I understand we have one comment that Mr. Wiggins wants to make, and then I will bring this to a vote.
Briefly, for the retirees that are still here and the ones that may be listening, a few words of appreciation. Through love, blood, sweat, and oftentimes tears, you labored for the Bossier Parish school system 30, 40, and even 50 years. You lovingly educated and cared for our children to meet every test. Your call and dedication to duty has made our school system the very, very best. Bricks and mortar didn't get this done. You all did it, and it wasn't always fun. A tree is known by the fruit it bears. Visit the campuses of Bossier Parish, and you'll see your wonderful work everywhere. You loved our children, patriotism, and the red, white, black, and blue. Nowhere in God's world will ever mistreat you. So Bossier Parish School Board retirees, we thank you, thank you, thank you for your years of labor, both day and night. And rest assured that the Bossier Parish School Board will never, will always treat you right. Thank you.
Thank you. I have a motion by Ms. Brotherton that we do not move forward with Medicare Advantage. I have a second by Mr. Cheatham. Insurance Committee, please vote. All those in favor? Okay. It is unanimous. We do not move forward with Medicare Advantage. I would like to bring up item number 2 on our agenda this evening, presented by Mr. Allman of the Allman Group. Mr. Allman? We start, if any of the retirees would like to exit, we'll give you some time to do that, a few minutes. I know Mr. Allman is difficult to listen to at times. So, they're voting with their feet, Jason.
They may need a pillow if they stay much longer. Y'all have a nice evening.
Okay, Mr. Allman. Mr. Allman's going to be, first of all, Mr. Allman is our independent insurance consultant, and he is going to be giving us information on closed formulary and EGWP. Mr. Allman?
So the first information I'd like to share is the information that we've gathered on closed formulary. This is some information that I've gone through with prior CFOs and with Ms. Bamberg, and we've discussed in an open meeting prior. Currently, the plan has somewhat of a hybrid plan. It has a listing of drugs which are covered as a preferred drug and drugs that are covered as non-preferred. So what you would be doing in essence is moving to a formulary listing where if it's not on the formulary listing, it's an excluded drug. Now, if somebody can go through the appeals process and get that drug covered, if it's the only drug that will work for that person, but they'll have to prove that they tried the other drugs that are on the list that they would work. When we looked into it, it represents about 777 people would be impacted on drugs they are taking today. It represents that about, about 2,941 claims out of 177,000, so 1.66% of the overall drug claims issued would be affected. So in essence, what will happen is instead of having an open formulary where if the drug's FDA approved, the member can get it, there'll be a listing of drugs that gives us the greatest discount, steerage to the ones that give us the best price per drug. It also does a tremendous favor for the plan in the fact that it closes that loop where a new drug coming to the market gets to be vetted before it's approved and added to the list. So in essence, you stop a new drug coming in that's unproven as far as the cost of the treatment and where else it fits. If it's FDA approved, but it's not on a formulary list, it's not going to be covered at that point until it is. So by closing a formulary, not only do you get a reduction in current claim costs, steering them to a lower costing or bigger rebate drug, which we get back, in essence, it also stops a high costing drug from impacting us. Unfortunately, as we've discussed before, that your health insurance plan is seen as a revenue stream. These drug manufacturers have a lot of arrows in their quiver on how they're getting access to you. Copay assistance cards, rebates, funds to doctors. They're concentrating on getting you, or getting your members to take their drug. I had a conversation, and I hope Mr. Gaspard doesn't mind me saying, I talked to him earlier this week. And he said, you know, the doctor prescribed me Xarelto, and, you know, it was on a higher tier level, but I got the copay assistance card, and it cost me $10. Well, so it might have been a $70 drug. He could have got the $30 drug, and it would have cost the plan less money and him less money. But since the drug manufacturer produces the copay card, they steer him to a $10 drug. So they're doing everything they can do to get you to buy their drug, and all of those copay assistance cards are baked into their cost. And so if you don't use it, you don't get the advantage of it, but the school board may be paying a higher price for that drug. When if you exclude that drug and you steer them to one specific drug over another, you get some discounts arranged with it. We went through the program, and there's a handful of drugs that represent the majority of the claims when we look at it, and a handful of people that would be, when you look at 777 participants, it's out of 8,210 belly buttons that y'all have covered, member lives. But going to a closed formulary, it would affect 655 people taking one drug, 97 people taking 2 or more drugs that would be non-formulary, and 25 would have 3 or more non-formulary drugs. Now, if there's a non-formulary drug, there's a drug on the formulary list that is covered, and they will work with them to steer it through the direction. Ms. Bamberg pulled together the list of those drugs that are listed on the form as far as the ones that were the highest prevalence. When you see a B next to the name, that stands for brand. When you see with a B with an asterisk, that is a brand with a generic equivalent. So today, we have a mandatory generic requirement. But if the member chooses to take a brand, they pay the difference of the cost of the generic to the brand. Likewise, there's an appeal process. If the generic doesn't work for somebody, they approve the brand. So in some instances, these people would be affected and these drugs would not be covered going forward. But it would be against the whole population of 8,200 people, and it would affect 777. And we would give them proper notice if this was elected. We'd give them 3 months advance, notifying them of the change to the formulary and the drugs that would be available to them as an alternative, and would have saved 7% of the gross drug spend, which represents right at $1.4 million.
Questions?
Yeah.
Yes, Ms. Brotherton?
Jason, how is this different from what we did a couple of years ago when we?
It just adds another level. We closed off a lot of things a couple of
Right.
years ago. Actually, it was 2015. We went in and we excluded branded proton pump inhibitors, branded sleep medication, branded allergy medication. By doing that, we closed off a lot of things that were being abused, because you could get Prilosec over the counter, you can get it brand. Well, when we exclude that brand, they get either the over counter or generic. So we're able to shorten it. Then we added step therapy, and then we added the mandatory generic, where they have to pay the difference. So all of those things save money, but now this is just narrowing the stream of the drugs they can actually use as far as a branded drug.
Still have their appeal if they couldn't find any other drug?
If they've proven that the drugs that are available will not suffice their condition.
Okay,
Will not treat
thank
their
you.
condition.
I have one question. We got this beforehand, and I've had an opportunity to look up these top 5, which are the majority of what we're talking about. Would you mind saying the illness that these drugs treat, these top 5 here?
So lolestane is a contraceptive drug for pregnancy. Restasis is an eye medication. Premarin is a hormone, and I believe the Urethrox is also a hormone. I can't remember what the Apido was. What's acne cream?
Yeah, it was an acne cream.
Acne cream. So again, when you look at these are, and there's alternatives to them that would be available to them of like quality. So again, we're already requiring people to go through step therapy. So a person doesn't necessarily get a branded drug unless they've proven that they've gone through the generic first and it hasn't worked, and 1 or 2 brands elsewhere. So we're just tightening the loop of which brands would be covered.
Okay. Mr. Bullard?
Mr. Chairman, at this time, would you entertain a motion?
Yes, sir, but I want to give everybody an opportunity to speak, if that's okay, sir.
Go ahead.
Mr. Dean?
Wanted to ask, what if a doctor is treating someone with cancer or something, and a new drug came out, and it was a miracle drug, but would you have to go through the generic drug before you get to that drug?
Well, if the new drug comes out, it's a brand, and generally the patent lasts. Right now, a lot of these are biologics, and there's really no patent life on them. I mean, you look at drugs like Enbrel, Humira, that have been out there 20 years now, and the price keeps going up because there's no biosimilar drug that's available. So the patent would have to expire before you would get to a generic equivalent that's available. Does that make sense?
Yeah. Well, but would you use another drug like similar to that?
Well, initially when it came out, once it was FDA approved, it would be reviewed, and the plan could either add it based on the formulary as the effectiveness of the drug, and it would be based on the effectiveness and the cost of the drug.
One more question from me. If you'll scroll back up to the page to the point Mr. Gaspard talked about earlier. All divisions of the Bossier Parish School Board's health insurance plan would be affected by this. Am I understanding that correctly, Mr. Allen?
Yes, sir.
Okay. Mr. Cheatham, you had a question?
I just have, no.
Yes, sir. All right, Mr. Bullard, I'll entertain a motion.
I make a motion that we accept the recommendation to transition to a closed formulary.
Second.
Okay. We have to open it up for public comment, of which I know that Ms. Bales has some questions that were submitted.
Yes, sir, you just have one. From Jennifer Hillman, she asks, she says, I am concerned that a closed formulary will make it difficult to work with my doctor to find what works best to manage my condition? Will the type of medication be limited to only certain doctors, and will this require multiple specialist appointments to treat conditions a single physician was already managing? What other options have been considered, and how will a closed formulary affect those who have complex medical conditions?
Can answer.
This would not limit any doctors. Whoever prescribes the drug, so long as they're a licensed physician, it will be covered by the plan if it's on the formulary listing. So it wouldn't be, you have to go to one specific doctor or one specific specialist to have a drug prescribed to you. There would be some limitations. And again, we're talking 1.6% of the overall drugs. Today, that winds up 209 individually named drugs, 84 of which have a generic equivalent today. So those people either went through the appeals process and got that brand approved, or they're paying the difference between a generic and a brand today.
Thank you for your answer. Anyone else that filled out a comment card here on the closed formulary want to speak? All right. I have a motion by Mr. Bullard. I have a second by Mr. Cheatham to approve the recommendation of the expert on closed formulary. All those on the insurance committee, please vote. We have a unanimous vote for that to move forward. We now are going to move on to the employer group waiver plan. Mr. Allman.
So the employer group waiver program is a step into Medicare. Today, the plan operates, the school board pays the prescription drugs on behalf of the retirees with Medicare, and that's retirees with both A and B, and A only or B only Medicare. It represents about 1,600 people that have some form of Medicare today. Again, you would establish a separate self-funded employer group waiver plan, is what the EGWP stands for. Under this program, the school board would get the advantage of the additional monies available through the federal government in the form of reinsurance, in the form of manufacturers' rebates or discounts that are in the donut hole. Overall, it represents about $59 per member per month of additional savings, which if all 1,600 people were moved to the EGWP plan, it would be savings of $1.3 million. We could structure the benefits the way that the current Bossier Parish School Board benefits operate, and there would be a difference in the formulary, but with the preliminary numbers that we've run through, it would impact 43 different name brand drugs that would go from a tier 1 to a tier 3, which is a difference of a $10 copayment to a $70, and it would impact 42 tier 2 drugs that would go to a tier 3 at a $30, but from a $30 copayment to a $70. There would be 43 drugs that would have an improved tier change from 3 to 2, from 70 to 30. So it's a very small number of named drugs that would be affected on this option, but it would impact some people. And again, we're moving to a more managed plan, okay, because it's got to abide by certain Medicare guidelines. We can't do a mandatory generic under it, so there'd be some cost give there. But with the other savings and the discount programs, it winds up being $59.06 per member per month.
On this one, as opposed to the other plan, is this controlled by the Bossier Parish School Board or an insurance company?
This is a self-administered EGWP a self-funded EGWP program. You would have an administrator. This one's based through Express Scripts to administer the EGWP program, but the parameters would be set up by the Bossier Parish School Board.
Okay.
And with the requirement that they follow the mandatory Medicare Part D requirements.
Okay. Any other questions from the board? Yes, sir. Mr. Downey.
Ms. Bamberg, I hate to put you on the spot, but based on the information you've been able to gather, at this time, what would be your opinion on this plan?
As far as the EGWP program, this one is going to be a lot more complicated than the closed formulary. We're probably looking at a little bit more time to implement. It's just a little more complicated. It's us putting into place a self-funded Medicare Part D is what we're doing. There are, it's not an appeals process, they call it a different name, but where they can, tier exception, where we can look at tier exceptions on their co-pays and things like that. When you get down to the nitty-gritty of it, it's going to depend on what amount of savings we feel like we need to do at this point. If we feel like with doing the closed formulary, we should see a 1.4 million savings across the whole population. If we feel like that's not enough savings for what we're trying to do at this point, then I do think, the EGWP is something good to look at. I think it's definitely not something to jump off into without knowing all the ins and outs of it and understanding those impacts. Jason's been doing an amazing job with that and with helping getting us informed. It is something we would have to hire an outside consultant to help with implementation of. There are implementation costs that we have to pay the first year to get that set up, and because there's a lot of regulatory items on this. I definitely don't think the EGWP is something that we just throw out and say that we're not ever going to do. I think the plan has been managing itself well, based on all the changes that the board has done, based on all the work that Jason puts in tirelessly, watching our plan and helping to make sure that we do what we need to do on that plan. Making sure that we know our large claimants, making sure our reinsurance is renegotiated, and things like that. I do think it's important that we always examine the cost and examine the savings, but I think the EGWP is just a lot more complicated before we move into it. I want to make sure that the board's aware of all the changes there as well. So,
Can you speak to those changes, Mr. Allman? Can you please take the microphone? We still have people that are watching from home.
If we do the EGWP, we will lose $400,000 of the savings from the closed formulary, because you can't have the closed formulary savings because now all those drugs are moved over to the EGWP program. So in essence, if you do the closed formulary today, it's 1.4. If we do the EGWP in the closed formulary, you're talking 927 on the retirees, actives and retirees without Medicare, and then the $1 million on. So we give up $400,000 by doing the EGWP program on the closed formulary savings. As far as setting up the plan, there's compliance issues that are required. It is a federal program. It's an independent Medicare Part D program. It's got to be offered just like an open enrollment would happen on any other Medicare Part D program. So we've got to make sure, and that's the reason for the consultant, that we cross all the T's and dot all the I's to get the program set up. Does that answer your question, Mr. Bass?
Mr. Dean?
What did you tell us about the $400,000 we lose when you were selling the program?
I wasn't selling the program, and again, I was looking at the numbers, and then as I sat there, I said, well, if we do the EGWP, and we've discussed this in multiple meetings, me and Ms. Bamberg, it just was an oversight.
Part of that is kind of how we had it divided out. Really, Jason was going over the benefits and the formulary changes as far as the EGWP, but I was responsible for presenting the numbers. We do have a schedule showing if we did a combination of the EGWP and the closed formulary together, and that is on page 10. And that does show that we would lose that $400,000. So the closed formulary savings are specifically listed in y'all's handout on page 7, and I wanted to show that specifically how that's broken out between active, retiree without Medicare, and retirees with Medicare. This EGWP and closed formulary, that's why you only see the two columns, the active employees and the retirees without. The EGWP would only affect the retirees with Medicare, but it would be the 1,600. It would be retirees with Medicare A and B, retirees with Medicare A, and retirees with Medicare B only.
Yes, Mr. Dunn.
Mr. Dean, Mr. Almonds also shared that information or that loss of revenue as far as EGWP is concerned with Mr. Bass, Mr. Bamberg, and myself. So he wasn't holding back that information.
And this was in the email that was presented to us or sent to us too, this spreadsheet. So, my question is, this savings is combined together, and to Mr. Gaspard's point, this would be these two items together would touch every class that we have, right? And to his point, we're not picking on any one subgroup by doing both of these for that combined savings.
Correct. It would touch every class. It'll touch the retirees with Medicare a little different than it touches the other two, but yes.
As I understand it, the same things that Mr. Almond talked about on the closed formulary, I know it's called a tier objection, a tier exception, and I know it's classified as a different term under the closed formulary, but in essence, it would be the same concept as far as an appeal if one drug would not work for the other. Am I understanding that correctly?
It actually is a little bit more enhanced in that through the tier exception program, if the higher costing drug the lower costing drug doesn't work, the member can do a tier exception and they actually get it at the lower costing copay. Through the appeals process on the non-formulary, if they go in and the doctor prescribes a brand name drug and they go through the process and it gets appealed and approved, they pay the higher brand copay. So it doesn't go back down to the generic copay, which it would on a tier exception, or the lower tier copay.
Simple, the tier exception would actually, they would get the lower tier copay not being out of pocket for the retirees, for those that are on a fixed income. Am I understanding that correct?
And there'd be some impact for those people that had drugs that would get to the catastrophic level on Medicare Part D under the program that's been modeled the cost. They would actually get the lower costing copay that's available of $3 or 5% on a generic, or $8 or 5% on a brand, whichever is greater.
So the retirees that we heard from during this process that were concerned about living on a fixed income and their cost escalating, this would be a process to where it could possibly be a cost savings for them.
It could be if when we look through the financial, the actual cost share of the member was actually reduced by about $9 per member per month.
Okay.
From $69 currently to $60.
Yes, sir.
Just point of clarification, the closed formulary also by itself affects all classes of employees, correct?
Correct.
So we don't have to include EGWP to make sure we
So when you do the EGWP, we're just
everybody.
talking about retirees with some form of Medicare. So the EGWP would only apply to those retirees with some form of Medicare. The closed formulary would apply against all classes if you didn't do EGWP, but the closed formulary would only apply to retirees, active employees and retirees without Medicare if you did the EGWP.
Any other questions? Mr. Allman, as our independent expert that does not get paid a commission but gets paid a consulting fee.
Yes, sir.
What is your recommendation to this board?
My recommendation is that you've got to look at all of the cost savings that's available to you. I look at this program and it's a step further from where we are. Today we're getting money from the retiree drugs subsidy back, and there's additional dollars out there. There will be impact. There will be a little bit different here or there as far as what drugs are covered in which tier. It will be a different format for some people that have a higher income. They may have to pay a higher premium to a surcharge under Medicare Part D, but the impact will be small, and it will be there'll be an appeals process in place.
That is controlled by us and not an insurance company, am I understanding? Our self-funded plan.
A self-funded plan administered by Express Scripts would handle the appeals process.
But again, we're not handing that control over to an insurance company, correct?
Correct.
Okay. Yes, ma'am. Ms. Smith.
So is the cost total savings, does that include someone administering
Yes.
The EGWP program? And
Yes.
we have found that person, or,
The suggestion from the consultants were that you would keep the same administrator or the same PBM, pharmacy benefit manager, so that when you shift it between classes from an active to a retiree, there wasn't a big shift in the card. And again, as pointed out earlier, this will be a separate card to your Blue Cross card. So this would be an individual Express Scripts card.
so the implementation of this, can you do this at any time, or is it on a January 1 date, or?
We can do it, it's my understanding, at any time, but the timeframe we've been given is that if we can make a decision, it appears that it can be done by January 1 at this point.
Ms. Bamberg, if it were able to be done by January time, as Mr. Allman said, what would the approximate savings be for this fiscal year? So January to the end of June. Half of that number, am I to understand that correctly?
Correct. It would be half of that if that's what we choose to do.
And so half of the, let's call it $1.1 million, so the savings between the two would be approximately this fiscal year, how much?
It would be about $1 million total, because both of those would be only a half year.
Okay. Mr. Cheatham?
Mr. Bass, I'd like to make a motion that we move forward with the EGWP plan.
I have a motion. Do I have a second?
Second.
I have a motion by Mr. Cheatham. I have a second by Mr. Bullard. Public comment, please. Mr. Bullard has a has a comment.
Just so there's no misunderstanding, this whole evening has been devoted to dollars and cents and potential cost savings for our health insurance program. As I have explained to a number of people over the last 2 weeks, this program does not operate on its own. It's not sitting there putting along on autopilot. It requires management and oversight on a regular basis. And one of our greatest responsibilities is to do whatever is necessary to ensure that not only do our regular employees and our retirees have health insurance today, but 10, 20, 30, 40, 50 years from now. And the only way we can do that, we have to stay on top of it. We have to manage it. And regrettably, some of this will require some modification. That's just the nature of the animal. And we still have a premier product. Compare it to the state group health or some of those. We have the premier product. So we're not constantly trying to find ways to nitpick this system. We're trying to ensure that this plan is perpetuated long into the future after we're all gone. So just please keep that in mind going forward. Thank you, Mr. Chairman.
Yep. One more point of clarification. I know that Mr. Allman said PBM, Pharmacy Benefit Manager, which is Express Scripts, which is what everyone currently has, correct? The closed formulary would be Blue Cross Blue Shield, which is what everyone currently has, correct? Correct. Okay. I see public comment, raised hand from a Blue Cross representative. That's a lot more handsome than his dad, but I'm sorry. I apologize.
Younger anyway.
Thank you. I just want to be clear, because you've asked it twice, Adam, Mr. Bass, excuse me. The closed formulary impacts retirees, active, people with Medicare, without Medicare. the EGWP impacts just retirees only, is that correct? Okay, so I just want to make that clear. I just want to make sure. We just went through a whole thing where we talked about MA, which is Part D is part of MA, and now we are excluding the retirees on a program. And I just want to make sure, 'cause since I'll have to answer some of those questions through public. So I just want to make sure I'm clear on that.
Thank you. Bikes. Okay. Exclusion. Mr. Allman. Right word, wrong word?
It's not an exclusion, it's a separate program. There would be an EGWP program set up to take advantage of the discounts from the drug manufacturers and the additional funds on reinsurance, federal reinsurance on the Part D program. So it'll be an actually separate Medicare Part D program. The actives and the retirees without Medicare would remain on the current prescription drug program that's managed by Express Scripts through our self-funded plan. And so there would be that differential, but it's not an exclusion over one over the other. It's just two separate programs established.
But managed by the same
Managed by Express
current
Scripts, yes.
Blue Cross Blue Shield and PBM as we currently have.
So the EGWP will be a separate program through Express Scripts, and it will not run through Blue Cross.
Okay. But Express Scripts runs
Based
our
on
PBM
our
now.
pattern of benefits as established by us.
Okay. And we control that, not an insurance company,
Yes.
as a self-funded plan.
And by doing the additional benefits not covered typically by Medicare, whether it's the donut hole everybody's heard about or the catastrophic coverage, we're able to close those gaps and not leave anybody exposed. We're able to put the cap on the out-of-pocket maximum at the $4,000 that they have now. Last year, we had one person that got over $4,000 worth of prescription drug spend in 19. Through 2020, we've had one person, through June of 2020, we had one person get over 2,100. So somebody getting over 4,100 is a very rare instance. And when we get to the format where we're getting the additional discounts in the donut hole from the drug manufacturers, that will be reduced additionally as well.
Any other public comment? Yes, sir, Mr. Backhouse.
Jason, you said that this would save the retirees $9 a month?
As far as when they shared the cost share projected savings on their modeling, currently they were projecting the cost share per member at about $69. And on the EGWP program, it was set at $60. So, and again, what that formats into is some drugs become a zero copayment, some drugs become a catastrophic cost where the federal government's giving us the money back as far as the federal reinsurance. And so all of that put into the format where donut hole people are paying 25% of a brand, and that's discounted by the drug manufacturer. They're paying 37% of a generic. Today, we're paying that full cost, and so is the member.
All right, thank you.
Mr. Gaspar. Mr. Gaspar, please take the mic. We have people watching still from home.
Help him
The two separate programs deal, you know, I just need to know how it's going to affect the Medicare people a little bit more, if that could be explained again, because I'm receiving text right now from people wondering about Medicare retirees listening to this program right now. So I'd like to know the effect on the Medicare people again, please, Jason, if you could go over that, and how does the effect compare to retirees and the regular employees?
So the first change would be it also will have a closed formulary. Okay, so regardless of whether you do the closed formulary as part of the entire group, actives and retirees, the closed formulary will apply to the retirees with Medicare. So it'll be a similar type closed formulary where it will impact some people, and some people will be shifted to a different class of a drug or a lower class of a drug. As far as, yes, sir.
Class or tier?
Tier.
Okay.
Tier.
Which is where that tier exception comes in.
Correct.
Okay, so I just
Where
want to
we
make sure
can-
I
where we can
understood
do the tier
tier and not
exception.
class. Okay, thank you.
Okay. And then additionally to that, the benefits that were quoted remain the same. Still a $10 level 1 drug, still a $30 level 2, still the $70 on the non-preferred drug, and 10% up to $100 on the specialty drug. So all the benefits and the out-of-pocket would remain the same. They would get the advantage of the catastrophic discounts as far as what's available through Medicare. There would be some shift. There's some shift from what was currently covered underneath the prescription drug program that would be covered under Part B, whether it's a test strip or a diabetes monitor. But again, all those benefits are paid at 100% today. So rather than get into the pharmacy benefit, they would get it through the Part B medical portion of it.
But they would still get it?
Yes.
Thank you. Mr. Gaspar, does that answer your question? Okay, thank you.
Adam.
Ms. Brotherton?
So Jason, the EGWP, is this better for our retirees with Medicare? Is this going to help them?
It will help them in some aspect. Again, the cost share should come down for the majority of them. It will help the school board in capturing those additional savings. It will help the member on a high costing drug that's in the donut hole where the cost will be reduced.
Okay.
It will help the people on the catastrophic deals where they'll pay the lower copay if it's available to them.
So our active members and our retirees without Medicare is the same?
It would remain the same,
Same.
except for y'all have already approved going forward, or the insurance committee has approved going forward with the closed formulary. So there would be that impact, but again, you look at the list of drugs and there are alternatives to those.
Thank you.
Yes, ma'am. Mr. Dean?
I'm not, at this point, for it. So convince me why we need to do this. Why is it better than what we have in the first program?
It's not significantly better than what the plan you have today as far as to the member. It's a savings to the plan.
It's a savings.
Yes.
Will retirees see any negative benefit?
There will be some impacted by the change in tiers for a drug. There will be a tier exception program that's available that they can appeal it if the lower tier drug did not work for them. They can go to the higher tier at the lower tier cost. It's an appeal process.
It's a tier exception, right?
Tier exception, but it's an appeal process.
And that tier exception is not controlled by an insurance company. It's controlled by the people that are still controlling it right now.
It's controlled by the pharmacy benefit manager.
Again, we still maintain our self-insured status, correct?
It's a self-insured separate fund.
Okay.
So it is not through.
I'm just making sure those that are scared about
So
the
these
government
drugs-
managing.
So when we set this aside at this cost savings, this would not be part of the self-funded claims that you have anymore. Okay, this will be part of the EGWP program and the EGWP program alone.
Okay. Additional questions? I have a motion and a second. I have a motion by Mr. Bullard, second by Mr. Cheatham. Do I remember that correctly?
I think you did the motion.
Motion by Mr. Cheatham, a second by Mr. Bullard. Any additional comment? Please vote. Mr. Dean, okay. Those against? Okay. Let it be noted that Mr. Dean voted against the EGWP. All right.
Thank you.
Thank you very much. Closing statements, I'd like to thank everybody that came out tonight, participated in this. I really appreciate the process. We have one more statement by Mr. Cheatham.
Yeah, Adam, I want to thank you for the hours of work that you put in on this. This isn't something we just, whip up. And I know you've spent for probably 2 months now a lot of hours researching this, getting information. Just want to tell you as insurance chairman, thank you very much, and appreciate your work on it.
Thank you.
Second that.
Thank you very much. All right, meeting adjourned. Everybody please drive safely.